Hello and welcome to another edition of For the Health of It. Thanks for joining us. I'm Lou Beccaria, your host. We sometimes hear that the practice of medicine is both an art and a science. Well, today we're going to concentrate on the science part of it. We'll be talking about how science and technology have contributed to making surgery not only more time efficient, but more importantly, safer and less invasive for patients. In particular, we'll be discussing robotic surgery. Our guest to inform us about robotic surgery and its contribution to the practice of medicine is Dr. Wasfy Fahmy, the Chief of the Division of General Surgery at the Phoenixville Hospital. Dr. Fahmy, welcome to the show, and thanks for taking time out of your practice to be with us.
Thanks for having me.
Well, first, just tell us a little bit about your background so we can introduce you to the audience.
So I've been here a long time in Phoenixville. I started practice in Phoenixville in 1981, so you can do the math. Been about 38 years, and I was privileged to see the progression of medicine as we do surgery. For example, when I started doing surgery, we would do open surgery on everybody, and then came laparoscopic surgery, which is minimally invasive, and we started doing that also. And then came robotic surgery, and that was and is the way of the future anymore, because whoever does not or is not able to conduct robotic surgery is going to have a limited scope on medicine. My background, I obviously graduated from Cairo University in Egypt a long time ago, and came to the United States in 1970 and passed my equivalency exams and passed the board examination and did internship and did general surgery residency program at the Medical College of Pennsylvania. Finished that and then went to Temple Hospital to do 2 years of accredited fellowship in vascular surgery, and then practiced up in the Northeast Philadelphia area for a short period of time, and then came and sort of hung my shingle here in Phoenixville, and since then I never left because I like the place very much.
Okay. I grew up in Northeast Philadelphia. Where did you practice?
The 5 hospitals: Kennedy, Warminster,
okay.
the big hospitals.
Yeah.
I used to circle 35 miles on call, so it
Wow.
was a little grueling.
Yeah, I'll say. What influenced you, doctor, in getting into surgery rather than another aspect of medicine, like family practice medicine?
So when you go into training, you sort of like find your niche at some time, and you figure out what you like most and what you fathom that you can do for the rest of your life and not be bored with it. Mm-hmm. And for some reason, when I was young in training, I thought I was going to be a cardiologist. Oh. And look at me now, I'm a surgeon. So things change, and you find your way as you are training, and you find your passion.
Yeah. So I'm just interested in what created the change from cardiology to but to general surgery for you? Was there something that occurred, or?
Well, when I came to the United States, I secured the job as an extern. They had externs at that time before I got into the internship and so forth. And I was a surgical assistant for a short period of time. And I liked what I did. And that really broke me into, this is something I really adore doing, and therefore I enjoy doing, and therefore I can go into it. Okay. With good passion and good motives. So.
Good. What is it? I'm kind of fascinated with the term general surgery, and yet there are specialties that engage in surgery, obviously. So what is the big difference between general surgery and, say, a cardiologist who might do surgery of the heart, or a doctor who does something on the liver or whatever?
So general surgery actually covers a huge spectrum of subspecialties. And when you go past the board examination, they actually question you about gynecology, chest surgery, cardiac surgery. There's a lot of subspecialties included in there. And they actually demand in the board examinations that the general surgeon will be equipped to answer and or practice some of these.
Oh, wow.
Because in some hospitals, you do not have an expert in doing open heart surgery. General surgeons are not going to do open heart surgery, but they can certainly do lung surgery, and we're all trained to do that. So general surgery is a big spectrum. It covers a lot of subspecialties. Now, with the advent of I am specialized in cardiothoracic surgery, that gives me an edge to be responsible and so forth, and insurances would look at it as an advantage, and also the patients themselves. This gentleman had extra training in there, therefore I have to go to him.
I see.
And then the general surgical field got subdivided a little bit, and rightfully so. So we're not expected to know everything about everything, and we're very humble about it. So there are a lot of expertise that we do not wish to think that we are experts in. And it goes to subspecialists, which is gynecology, orthopedics, open hearts, and lung surgeries and so forth. So general surgery, many general surgeons are still able to do major surgery on the chest and so forth. Many of us turned into doing gut surgery, abdominal surgery, hernia surgery, that type of approach.
So in a sense, as a general surgeon, you're kind of like a Renaissance person. You can do lots of things, but maybe not in the same depth as say a specialist in cardiology or orthopedics or gynecology.
That is correct. So, and also I have a subspecialty because extra training in vascular surgery, so I was still able to do open vascular cases, as in bypasses on the legs, bypasses on the arms, and carotid artery clean outs to prevent strokes and so forth. So I still am able to do that.
Wow. So in the practice of general surgery, doctor, I assume you practice in a team. Who are the members of a team that you practice with in doing your surgery?
So right now we have 3 active surgeons, general surgeons, in one group. And then there are 2 other vascular surgeons that cover the hospital for vascular issues. So it's a total of 5 surgeons. Now, the Tower Health had already signed up a robotic trained person that just finished or is finishing her fellowship in robotics training. And is joining us in September 1 of this year. So that makes it a 6-man group. The group is not under the same name, but they subscribe to the care in Phoenixville.
I see.
So all services that are needed to be covered from the emergency room point of view are covered for that.
Okay. Okay. So there's more adequate. So in a sense, the patients and the citizens of Phoenixville are more well cared for that way.
You have to be able to supply what is demanded.
Sure. Yeah. And as the population of the greater Phoenixville area has increased, obviously we need more doctors to take care of those kinds of situations.
Correct.
Okay. We have the pleasure today of talking with Dr. Wasfy Fahmy, who is the Chief of General Surgery at Phoenixville Hospital. We're going to take a break and hear more from Dr. Fahmy after this word from our sponsor. So please stay with us. We'll be right back. Hi, welcome back to For the Health of It. I'm Lou Beccaria, your host. And for those of you who may be just tuning in, we have the pleasure today of talking with Dr. Wasfy Fahmy, who is the chief of the Division of General Surgery at the Phoenixville Hospital. And we're going to get really into depth here about robotic surgery. So, doctor, you started out at a time 38 years ago when there wasn't robotic surgery. Is that correct?
That's correct.
And when did robotic surgery come into being, and how has it really helped medicine?
So robotic surgery was available actually in Asia and Europe for a while before it came in here. We got a whiff of what's going on, obviously, in 2006, and that's where we contracted our first robot. And since then, you'll be amazed to know that Phoenix Hospital has 2 robots. One is the latest edition, which is an XI, and one is an SI, which is an earlier program. How we got into that, we realize now that, actually, I'll sidetrack. When I was in training, that was a long time ago, I had a chief of surgery that said, Fahmy, my man, big surgery requires big incisions. And now I look at it and I'm taking a colon out of a very small incision, and I'm wondering if these words were right. That just tells me that research progress are fantastic, and I'm privileged to have started open. And now we realize that, you know what, making smaller incisions help the patient. How, you say? Okay, you do a small incision, you get less pain. Wonderful. Do a small incision, you get less chance of infection. Wonderful. Do a small incision, you get less chance of hernias. Wonderful. Do a small incision because it's minimally invasive surgery, and you do it with the robot, and the robot has that much magnification, 10 mag, 3D vision. So it's enviable to see what I see when I'm doing robotic surgery. Why am I telling you all this? Is because you can really see very detailed pictures of the tissues, and make sure that you're going to be clamping all the vessels before you cut them. Therefore, you end up with a surgery that is minimally invasive only for pain? No, for blood loss also. So you end up losing, I would do colon surgery. I could remove part of the colon and put you back together and lose maybe 50 cc's of blood. If you think that you have 5 liters of blood in your bloodstream, I don't really have to correct that at all. I just follow it, and you are in and out of the hospital in a very short period of time, and you're doing well, and you don't need any blood transfusion, and on and on and on. So there's a myriad of good things that happen with less invasive surgery, not more invasive surgery.
So off camera, doctor, you were telling me that actually one of the newest things is bloodless surgery. And it was fascinating, so I'd like to invite you back to actually do a whole show on bloodless surgery, because I'm sure our viewers would love to hear about that.
Be glad to do it, because it's really an important issue. Not too many hospitals have bloodless systems going for them, and this system was implemented about 5 years ago into Phoenix Hospital. I had an issue with patients that were referred to me for colon surgery, and because the hospital was not declared as bloodless, they decided to go downtown for a bloodless institution. So I researched it a little bit and tried to figure out why, what does it take to become a bloodless institution, and work with the administration, which is really highly recommended and applauded. And the issue is, yes, there's a Jehovah's Witness community around that need the service. So instead of passing by us to go downtown, we created the service for them. And then soon enough, the understanding of a lot of people is giving blood transfusion is bad, and therefore it has a lot of risks. And therefore, not only not only Jehovah's Witness community rejects blood transfusion, but also a lot of people that know about blood transfusion do not want it. Sure. So the population is ever increasing, and that would be a fantastic show.
Yeah, we'll definitely do that, Doctor. Very much. We'll have you back to do that. So, tell us about the training to become competent in robotic surgery. I mean, it's in a previous show we did a number of years ago, I actually saw it, but I'm fascinated by how a doctor can actually learn to manipulate.
So it takes a lot of hand-eye coordination, and it's the huge input into it is that you really need to know the human anatomy cold. If you don't know it, you're going to get confused and you're going to be doing wrong things. Mm-hmm. So it's a prerequisite that you know what you're dealing with and the focus that you're adapting to. very clearly. You know which structures you're dealing with,
Right.
what is behind this, what is here, what's there. So if you're cognizant of all these things, you can conduct safe surgery. Let me go back to your question, training. So again, I feel privileged because I started with general surgery. I knew my anatomy cold, did laparoscopic surgery for a while, but they gave me the hand-eye coordination of how to move my hands to do this or that maneuver. Now came robotic surgery, and because of my knowledge from before and experience, I was sort of, I adapted to. So I did not go to specific training as in a residency program or a fellowship program.
Mm-hmm.
But indeed, I received training. How's that? You go to institutions that do robotic surgery, you see hands-on cases, for sure. You do animal lab, for sure. You do cadaver lab. So it's not only like you look at a picture and you're going to do it. No.
Mm-hmm.
You are experiencing the actual doing either on an animal lab or a cadaver lab. And these are spread around the city. Temple does them, a lot of other hospitals do them. So you go to so many of them. Now, once you start, you declare that you want to do robotic surgery, they would sponsor you and they say, okay, we're going to look at you carefully. So they get somebody that's trained in vascular, in robotic surgery, they bring him in and he will coach you once or twice doing the robotic cases to see if you are able to do them or not.
Right.
We have a program, a group of people that sit down and critique what you do, and then declare that you're efficient after you had done at least 20 cases without issues and complications.
Yeah.
So,
wow.
now the latest is after you finish general surgery, this day and age, see, I was from the old age, right? Okay, the new age now happens, you finish general surgery and there are equipped, certified fellowship programs, either 1 year or 2 years, purely robotic surgery. They don't do anything with any instrument other than a robot.
Yeah.
So this is the efficiency that they're adapting to and acquiring along the way to get to be efficient in that.
Okay, great. We've been talking with Dr. Wasfy Fahmy, who is the Chief of General Surgery at the Phoenixville Hospital Tower Health. We are going to take a break for commercial. We'll come back for the third segment, and we'll hear more from Dr. Fahmy on robotic surgery. Stay with us. Welcome back, everyone, to For the Health of It. I'm Lou Beccaria, your host. We have the pleasure today of talking with Dr. Fahmy, who is the Chief of General Surgery at the Phoenixville Hospital. And we're talking, for those of you who are just tuning in, about the whole area of robotic surgery, and it is absolutely fascinating. So you want to pay close attention to the third segment here. One of the questions I'd like to ask you is, you've made a point of saying that, you know, you can, with the robotic surgery, you can do things with a small hole. How do you get larger organs through a small hole, doctor? It must be magic.
Not exactly, but comparatively speaking, when you make an incision to take part of the large bowel out, it's going to be a little bigger than millimeters. It's going to be 3 centimeters. That's standard for us. So standard to take a tumor inside the colon out to the belly would require something like 3 centimeters. If you think about 3 centimeters, it's only 1 1/5 inches, which is still a small incision by definition.
Yeah.
Patient is asleep, muscles can relax, you can stretch that area. And what we do usually, if we cut the colon out, part of the colon out, we actually, the technique is to place a plastic bag through one of the ports, open the plastic bag, put the colon that you resected inside the plastic bag, noose it, and then when you're ready to take it out, enlarge one of the ports to 3 centimeters, and you'll be able to take that whole tumor out.
Wow.
So in other situations when a uterus is being removed, hysterectomy, if the uterus is small enough, it can be taken out of an orifice that pre-existed. So it's not unforeseen, but still, compared to the big incisions that we used to make in the olden times, it's like It's a trifle.
Wow.
Yeah.
Doctor, are there any types of surgery for which robotic surgery is not recommended?
I, yeah, there are modalities of or specialties of surgery that may not lend itself or themselves to robotic exposure. But we came a long way. We didn't think that ENT will adapt to that, and ENT is doing, is being done with robotic surgery. Certainly, heart surgery they're doing with robots. Lung surgery they're doing with robots. General surgery, as in removal of colons, doing hernia repairs, doing esophageal hernia repairs, and a multitude of things can happen in the belly, all are lending itself to robotic exposure. GYN, urology, actually the biggest use for robotics was in removing the prostate.
Oh.
Because the instrumentation is very thin, it's slimmer than my fingers, and it goes farther and deeper with fantastic control.
Wow.
So the prostate is deep-seated in the male pelvis, and the male pelvis is very tight. So, but there's nothing experimental about what we do anymore. Everything came a long way. Everything is well established. And it's not like, let me see if I can do it this way.
Yeah.
Of course, to answer part of your question is, I can't do everything with a robot. And why is that? Supposing somebody who got operated on 5 or 6 times before, the abdomen is full of scar tissue. That is called actually a hostile abdomen. Hostile, yes. It's very difficult. Even when you open it up, all the scar tissue you have to take down. It takes a long, long period of time to do the surgery and do it safely. So there are certain situations that not every situation fits to be done robotically.
Yeah.
Meaning that the glove doesn't fit everybody's hand.
Sure.
So you have to use your judgment. And we always give the patient a chance. We will start robotic, and if we're not able to conduct it robotic, we will convert it to open and do what we need to do.
So you can switch in the middle of a procedure?
Yes, sir, you can.
Wow.
For safety, for I'm not able to accomplish this in a robotic technique because it's going to be very difficult, or I can injure something, and we were born and raised not to injure.
Sure.
So,
absolutely. Who are the ideal patients for robotic surgery, if there is such a thing, doctor?
Fairly healthy, fairly young individuals without comorbidities. The comorbidities are other medical situations that can weaken your acceptance to general surgery. So if the patient has lung disease, that I can't put him under general anesthesia. Robotic surgery has to be done under general anesthesia. Why? Because I'm going to blow the belly up with carbon dioxide. Why? Because I want to lift the belly wall up so I can see what's under it, so I can work on it. When I do that and you're awake, you will shock out. Why? Because I'm stretching your peritoneum. If I stretch your peritoneum, vagal response will happen, your heart will slow down, and you will shock out. So there is no robotic surgery without general anesthetic. The patient is not a candidate for general anesthetic either because of heart or lung disease and other comorbidities, then he will not be a good candidate for robotic surgery. Simple, straightforward situations. Certainly, patient that was never operated on and requiring abdominal surgery, that is a dream. And issue with BMI, which is the body weight, came and went away because robotic surgery is being done now for bariatric surgery. So the bariatric surgery is being done with the robot.
Okay.
So the size is not an issue anymore.
Not an issue.
So we take on bigger BMIs with good results because these are the people that would fit better because the complication rate is much less.
Yeah. Dr. Fahmy, where do you see robotic surgery going in the next 5 years? Do you feel that it's reached its maximum potential, or there's more potential to do even bigger and better things with robotic surgery?
It's funny because when I started doing robotic surgery, I thought it's going to be a very limited scope. a very limited scope. We're going to do a hernia here, a colon here, this and that and all this stuff. And there are people that live in the city, right, in Philadelphia, that actually do pancreatectomies, removal of the pancreas with the robot.
Wow.
So is there a limit to imagination? No. Is there a limit to research? No. Is there a limit to, no, you can't do this because it's such and such? No. People are trying, and the research is going on rampant. And like I said, all these situations happened already. So it's not an experimental issue. It's adapting to what other people had found and had worked with. And Intuitive Company, I don't have any attachment to that, but it is the company that makes the robots. And this company is forever researching, forever improving the instrumentation and so forth. So it makes it much easier for us to adapt and go deeper. So we just scratched the surface with this.
Wow. Well, that's encouraging. That's encouraging. So, as Chief of General Surgery Doctor at Phoenixville Hospital, where do you see general surgery going in the next 5 years? You know, what growth opportunity is there at the Phoenixville Hospital for doing all kinds of new things?
Fantastic, I think. The more, it's really an education process, if I may put in a plug. It's an education process, as in, if you educate, we don't go and look for surgical cases. It is a matter of a general internist or a general practitioner would find the case and send it to surgeon. So the more education they have for general internal medicine and so forth, the more they know that, yeah, this could be done with a robot. And they send it to a robotic trained surgeon, and he can conduct the surgery safely with less blood loss and all the good amenities that I mentioned before. So do I see an end to this? No. Do I see progress? Yes. Only with a little bit of education.
Wow.
Yep.
I wish we had more time to talk about this, because this has really been fascinating, Dr. Fahmy. So thank you very much.
My pleasure.
We've learned a lot about robotic surgery. So thank you. Appreciate it. Well, that'll about do it, folks, for the show for today. We hope that you've been able to have some more insight through the expertise of Dr. Fahmy into robotic surgery and what it has to offer today in the practice of modern medicine, and how it might help you sometime if you ever should need it. Until we meet again for another edition of For the Health of It, if you'd like to always sign off with this, folks: if you're healthy, you're wealthy. I'm Lou Beccaria, and we'll see you next time. So long, everyone.